Donal, thank you so much. And to Joe, thank you so much for inviting me here today. I'm really honoured and privileged to be here. And to all from the Glenties, you live in a beautiful place. And I really enjoyed arriving here this evening in the sunshine. And it's wonderful to be here. So I suppose I'm going to start by saying I think there's lots of good things about our health service, lots of very skilled staff, and every day lots of triumph against disease. But we have huge challenge, and that's irrefutable. To me, I think this is a story of accidental, outdated infrastructure, chronic underinvestment in people, and a growing and difficult bureaucracy. But you know, we're asked to speak today on our dysfunctional health service. Are we about to find a remedy? Well, if a remedy is something that cures a disease, we must first make the correct diagnosis, and that's the doctor in me speaking, if we are to treat the condition successfully and avoid the potential of making things worse. In the last decades, we have lurched from one political health form to another without any clear diagnosis or treatment plan, albeit with very high expectation and plenty of promises that cannot or have not been kept. And at times, both patients and frontline healthcare staff alike have borne the brunt of political medicine treating somatic disease. So the antecedents of our difficulties, as always, lie in how our hospital system has developed. And I think it is worth taking a little trip through history to look at why we are here and to understand how our hospital system and community system has in fact developed. This is a story of an accident of benevolence, infectious disease, Catholic emancipation, and the infamous sweepstake bonanza. So from the parliamentary grants of the 1700s, which began the voluntary hospital system when the state was unable to provide any state care, and long before, in fact, the Irish Free State was formed, this was followed by other benevolent contributions, including the Dublin Industry Hospitals, the cholera hospitals, the workhouses of the famine, the religious voluntary hospitals founded after Catholic emancipation. In time, the workhouses became the county hospitals, the TB sanatoria were planned and some were built, and numerous nursing homes were opened. And by the time the Free State emerged in 1922, our predilection for incarcerating individuals deemed insane and pregnant women was well underway. The result was a myriad of small hospitals developed without any particular strategic plan. The 1953 Healthcare Act and the arrival of VHI in 1955 provided much greater coverage for in-hospital care and really much less support for community care, thus sowing the seeds for the hospital-centric care that is offered today. By 1965, Ireland had 169 hospitals, with only 3 of those hospitals having more than 300 beds. And this provided about 7.3 beds per 1,000 population. At the time, the UK, which had the NHS, offered about 4.3 per 1,000 beds per population. Today, we have 2.4 beds per 1,000 population in our acute hospital. So in the 1970s, efforts were made, and some were successful, to rationalise our hospital system. But of course, any effort to rationalise hospitals is often met with stiff local and political resistance. So today our hospital system remains a hybrid of the voluntary hospitals that were set up because the state was unable to provide care as charitable institutions, and they provided services to the state and continue to provide services to this state under service arrangement, and the HSE hospitals who are funded and managed by the HSE. There's over 17 voluntary hospitals, and they do have independent governance structures. They report to boards, and actually it is these hospitals that provide the majority of tertiary or sophisticated care in this country. So in business terms, the state purchases services from the voluntary hospitals because it is unable to have the capacity to provide those services. This arrangement, as we've heard, is often portrayed as a charitable donation to charity with no regard for the services that are obtained and indeed no effort to estimate value for taxpayers' money. Voluntary hospitals do guard their autonomy because they recognise that this autonomy is the root of innovation, strategic development and responsive decision-making close to patients. Anyone who runs a hospital for a day knows that you must be able to determine the staff you employ, the building you occupy, and have control over the services you deliver. Because the whole point of healthcare is service delivery to patients, the ability to treat patients. And it is certainly worth noting the proportion of tertiary services that has developed within the voluntary hospital system, and I believe it is because of that autonomy and innovation. However, at times this autonomy comes into conflict with national strategic plan, And it's going to be interesting to see that what the forthcoming review of voluntary hospitals makes of this. But I would say that if we are going to review a hospital system, surely we should also review the HSE hospitals and look at how the hospitals interact and the transfer of patients between the two systems. So in this background, Ireland faces increasing healthcare demand following a period of acutely reduced resource during the recent recession. The years between 2012 and 2016 saw an average annual deficit in the acute hospital system of some €210 million. Unrealistic and late allocation has led to hospital rationing and to impaired service innovation. The traditional late cash injection in December into hospitals, although very welcome, does little more really than balance budget, but it does not facilitate coherent budgetary planning. We need to have rolling budgets over 2 to 3 years and not the annual late budget that sometimes we don't get our allocation until January, February, and we're starting the year trading blind. Perhaps the most damaging of all, though, and it's no one's fault, these were necessary changes during the recession, was the moratorium on staff recruitment. But it was a pretty blunt tool, and it's been deeply damaging. And to this day, it remains really difficult to get approval to actually recruit additional consultants and other frontline healthcare staff. On top of this, the last decades have seen sharp changes in the demographics situation in Ireland. So our population has increased, and so has the demand for health services. Irish fertility rates remain at the higher end of the European norm at about 14 per 1,000 population, and our population has increased by 12% in the last decade. It now stands at some 4.7 million. And during the same period, there's been a 35% increase in people aged more than 65, and this cohort now accounts for 13% of our total population, with a further projected rise of 17% over the next 5 years. This is important because patients over 65 years are more likely to suffer from chronic disease and account for over 50% of the total in-hospital population beds and over a quarter of all emergency departments, all attendances at emergency department. So how do we address the challenges in Ireland? So in good health, a healthcare system will do the following. It'll prevent disease. It will provide timely access in an appropriate care setting. It will provide competent care to those attending, and it will strive to consistently enhance experience and outcome. So let's consider these elements in turn. So the first is prevention of disease. The prevention of disease gets so little attention, and our focus often directed on expensive treatments of chronic disease. But modern healthcare all over the world has shifted from acute episodic care to the treatment of chronic disease. And indeed, when we look at the difficulties the NHS are facing at the moment, the difficulties that many of the health systems are facing in the Western world, it is because just of that shift and increasing demand. People are living longer with more morbidity, and which is hugely influenced by lifestyle factors. But of course, first you have to be born, so I'm going to plug in for obstetrics, and of course perinatal health deserves our investment. But following birth, and people don't often think about this, the single biggest determinant of good health is education. Research has shown us that well-informed, educated people make better decisions about lifestyle, and they're also economically better off, so they're able to afford those decisions. This is a major societal issue, and so social disadvantage actually begins in utero. It's worth considering the precursors of the majority of our chronic disease: smoking, drinking alcohol to excess, drug addiction, malnutrition, obesity, lack of exercise, and psychological stress. These lifestyle factors are highly modifiable, but we make very little real investment in disease prevention as a country, and this has got to be a key pillar of any health strategy moving forward. So let's deal with the issue of access to care in an appropriate setting. It's unassailable that patients should have access to healthcare on the basis of medical need and not on economic means. I don't think there's anybody in this room who's going to disagree with that statement. 40% of Irish patients have full eligibility for healthcare, and 45% of the population have private health insurance. There may be some overlap in these figures, but there's clearly a vulnerable group in between. And it is clear that people defer accessing healthcare because of financial constraint. There's no doubt that patients with private health insurance have faster access to a wide range of medical, surgical, and diagnostic service. And there's a wide range of approaches to this in Equity International with mixed success, but Ireland is going to have to find a solution based on its own unique demographic and infrastructural situation. When we look at current healthcare statistics in our acute hospitals, they demonstrate clearly the difficulties and the delays in accessing public healthcare. It's impossible to provide a comprehensive list, but I think the following figures warrant our consideration. Elective surgery cases have reduced by 54% since 2012. That's a reduction from about 187,000 cases to 86,000. These cases can't be performed in the community. Inpatient day case waiting lists have increased by 12% in the last year, and outpatient waiting lists have increased by 15%. But most worrying of all, the number of patients on trolleys who have received treatment on trolleys is up by 58% in the last 5 years alone. We have 2.9 doctors per 1,000 population. The OECD average is 3.3, and in fact we have the lowest number of obstetricians in the OECD despite high fertility rates. We have 2.4 per 1,000 acute hospital beds, and the OECD average is 3.6. So we really are looking at a problem. My diagnosis here, we are looking at a problem of capacity. There are 600 patients at the moment with documented delayed discharge, and this figure has ranged from 450 to 800 over the last 3 years. The IHCA today in their pre-budget submission have estimated that we are short 290 ICU beds and 4,000 acute hospital beds. A mere 6% of healthcare budget is spent on mental health service, and when we look at whole-time equivalent employment in our mental health services, it's about 23% below recommended levels. Paradoxically, Ireland has 49 acute hospitals and a population of 4.7 million. And this might seem generous by any standard, but some of these hospitals are relatively small, and despite the number of hospitals, the number of beds in our system is significantly lower than OECD average. In addition, what people don't discuss enough is the fact that most of our hospitals are in fact effectively 4 hospitals in one. An acute adult centre for medical and emergency presentation, a general practice facility, an elective procedure hospital, and a hospital for care of the elderly. Now, these 4 groups have very different requirements, and over 600 beds in Ireland are occupied for long-stay patients who need rehabilitative and enabling care and not acute care in our hospital system. Therefore, any estimation of acute bed numbers does not provide a true picture of the capacity within our system, and this really is a problem of capacity. And this, of course, contributes to the long waits in EDs throughout the country, and how often do we wake up to hear the trolley count every morning and imagine what it must be like to be a patient receiving treatment on a trolley. From the outset, the lack of focus on community services has certainly contributed to this. While not all patients who arrive to an ED department can be treated in the community, certainly the admission rate figures are vary between 25 and 33%. That does mean that a significant amount of this care can be delivered in the community, but we still require the capacity to admit those patients who require in-hospital service. At community level, the legacy that is left right back from our history of hospital-centric development and poor development of community care means that GPs often work in isolated practice, and the auxiliary services are provided by private practitioners in a way that favours market forces in urban areas, and it really does create a huge problem in rural areas. And so the result of our haphazard accidental infrastructure is the dilution of clinical staff across multiple sites that are expensive to run and maintain. And of course, as our transport infrastructure improves, we need to focus on getting patients into hospital and not getting hospitals over to patients. I mean, the large territories of Australia and Canada and their transport systems provide plenty of examples of how this can be achieved. So against these figures, it's actually quite easy to understand why some people feel forced to take out private health insurance and why a private healthcare system, in fact, has developed in parallel in Ireland. People access private healthcare for a range of reasons, including access, choice in regard to a treating physician, and accommodation. In turn, private institutions can cherry-pick low-risk, high-volume procedures that maximise income, while expensive and highly specialised procedures sometimes need to be carried out in public hospitals. Indeed, the 1970 Healthcare Act and the 2008 Consultant Contract recognises the reality and actually the necessity of private healthcare to provide additional capacity within the system. Every year, almost €700 million is generated in income from private patients in public hospitals, and in a very highly expensive mechanism, the National Treatment Purchase Fund provides private care to public patients to relieve waiting lists. And yet we don't build up the capacity within our public system. In my own hospital, 1/3 of our income is generated from private patients. There is no private obstetric hospital. And curiously, access is a little different in labour. There can't be no waiting list and trolleys. And when it comes to labour, the babies will just arrive. But the hospital wouldn't function without this income, which represents about 20 million per year, and that is used to treat all patients, whether public or private. 69% of funding in Ireland is raised through taxation for public healthcare, is raised through taxation, 13% through public health insurance, and 15% from out-of-pocket payments. This suggests that the cost of private healthcare provision in private hospitals is in the order of several billion. And should we actually succeed in creating a one-tier system, and I really believe that would be a very good thing, we've got to factor in this cost as well. It's not a mere 600 or 700 million, it's also the capacity provided in the private healthcare system at the moment. Let's move on to the issue of competent care, because that's what it's all about, competent service delivery. Irish universities and postgraduate training schemes are not producing sufficient numbers at the moment to sustain hospital and community requirements. This position is further exacerbated by the loss of graduates due to terms and conditions pertaining in Ireland. A great deal of attention is paid to remuneration, and I should know, but much less is paid to working conditions in Ireland and to the low morale of staff on the front line. Long hours, inadequate staffing, poor working environment, unattainable expectation, personalised and sensational media reporting, and a spiralling and highly adverse medical negligence system are just some of the problems. State claims report that the liability for clinical claims was 1.6 billion at the end of 2016, a 23% rise on the previous year, with 65% of that accounted for by maternity care. And that is, of course, because of the large settlements in cerebral palsy. The current trajectory of rising legal costs is unsustainable, and this is money that does not get spent on the front line providing services. And the growing difficulty of attracting nurses, midwives and doctors is a critical issue with long-term implication for service provision. Sometimes people give the impression that it must be a great life to be a consultant, you just get paid and you do no work at all. Why is it then that the IHCA estimate that there are 400 permanent consultant posts that are not filled on a permanent basis with all of the attendant clinical risks, the expense of locum appointments? It costs about €360,000 to employ a locum consultant, and yet we do, rather than actually employ the right staff in the right hospitals. Insufficient attention is paid to this. I grew up in a country in which I worked 80 to 100 hours every week in training, and I don't think anybody really gave a damn about that, and I still work about 60 to 80 to 100 hours on call, and that's what our life is like. I love my job, but it is stressful at times, and it is also really long hours. And when you're on call, you're in and out of a hospital wondering what on earth is going to happen. And if you have an adverse outcome, how will that be treated in the media? How will that be treated in the medical negligence system? And we are losing doctors because I believe that people on the front line are becoming scared to practice medicine in this country. And this is something we really need to grapple with, or we will find it even harder to recruit people. If we do not support frontline staff, we in turn do not support our patients, because they require the care that is provided by people who spent years in training. And we must consider broader issues than simply remuneration. That's a very easy argument, but it misses many of the important points that are actually driving employment and recruitment in this country. I think patients coming to hospital want to be seen by trained doctors, not doctors in training, but in our current system we have far more doctors in training than consultants. We need to invert that ratio so that people who come to the public hospitals will actually see consultants and not registrars and SHOs. My hospital has 10 whole-time equivalent obstetricians to oversee 9,000 births. This is not enough. It's about a third of what we need, and it is really low by any kind of international comparison, and particularly as we are a tertiary hospital. Patients get sick 7 days a week, and hospital and community care facilities are expensive assets which should be utilised efficiently. Increasing the working week will allow us to actually deliver more and have a major impact on waiting lists. Not an easy transition, and the recent heated debates in the UK are highly instructive. Nearly there. In terms of experience and outcome, we must understand the benefit of detailed outcome data. It is deeply inappropriate to provide care without knowledge and monitoring of clinical outcome. Such reporting should be a norm throughout our system and should be the subject of detailed analysis of trends so that we can direct healthcare strategy. A major barrier to the system at the moment is the lack of standardised data collection and no universal IT system. We have a myriad of IT systems that don't talk to each other, and this is a major barrier to data collection and understanding how we do. At the moment, we are instituting the maternity and neonatal clinical management system. It will revolutionise data collection and analysis, but we need a national infrastructure and one that talks to each other. All of the dysfunction and problems with information retrieval and dissemination between the various healthcare entities will persist despite costly investment. And finally, to coherent management in Irish healthcare. At hospital level, management structures are clear and accountability is defined and understood. Above the hospitals, the myriad of reporting relationships makes accountability difficult to define and communication suffers. In recent years, we've increased the number and complexity, not just of people in administration above the hospitals, but actually the number of administrations above the hospitals. In my own case, the maternity programme, Ireland's healthcare group, the HSE, the Department of Health, there's a range of administrations who sometimes appear to have competing and conflicting interests, and it is very hard from my perspective to know how do I achieve, who do I talk to actually get things done. Currently there's a group structure which exists but has not yet achieved legal status, and it certainly hasn't achieved the intended delegated autonomy and the transfer of decision making. With this structural development, one might anticipate a realignment of HSE function, and indeed I know there is major structural organisation going on there, and also staffing reduction, but in fact we've just seen a 13% increase in corporate HSE while we struggle on the front line to get approval for consultant posts and other frontline staff. Newspapers allude to a 40% increase in senior management staff in the management structures which sit above the hospitals. And these trends, of course, are reflected in confused lines of accountability and authority. Throughout the structures, the instance of acting positions, so 2-year posts, 3-year posts, and the level of churn in these administrations is something that really worries me, because it is very difficult when you establish relationships and you try to do business to start all over again with the next person who comes in and has to try and grapple with the next job. This doesn't work. We need stability in our management system. So I've been given instructions to finish now. So the current healthcare problems stem from inadequate capacity, my diagnosis, a dysfunctional infrastructure and disordered administration and funding. And these issues have got to be addressed, and the solution will not be found in short-term political cycle nor in popular promises that are easily made and impossible to implement. The ultimate goal of a one-tier system based on clinical need rather than financial means is an unassailable aspiration, but a wide range of complex, expensive steps must be taken, and politicians, clinicians and society alike need to buy into the reality of the challenges that are faced and the actions. We can't make any promises that sound good but are unable to be implemented. There have been lots of attempts at reform, and I'm not going to reform the health system tonight, but I want to give you a few suggestions maybe that I think would make a big difference in actually delivering service to patients, because as I said, that's what it's all about. 1, there has to be a serious attempt to address disease prevention programs, beginning in utero and focusing on robust educational systems in our schools. Educational standard is one of the greatest predictors of health. 2, we cannot afford every element of healthcare provision, so we must develop the concept of priority medicine and the provision of protected core services for all citizens. 3, without appropriate staff, services cannot be delivered. We must address the current deficit in routine staff and develop coherent strategic workforce planning, and this begins at entry to university and other teaching institutions. 4, we must rationalise our healthcare infrastructure if we're going to provide appropriate capacity. Collaborative healthcare must be the cornerstone of future capital development and will require major investment to achieve efficient capacity. Effective models of healthcare demonstrate that healthcare should not be fragmented but should be delivered in a campus setting with different entities co-locating, providing a collaborative breadth and depth of service and care in close proximity. This enhances service delivery, achieves economies of scale, enhances training and education, and of course research must be an integral part of this development, and the universities and hospitals must be aligned in this requirement. And this will mean moving away from small hospitals delivering a wide range of services to large collaborative developments that deliver specialised tertiary and quaternary service. And the development of these structures would best be developed within the group or network service, and the group at this stage should formally be adopted, and we need to progress. 5, The existing administrations above the front line should adopt to allow proper devolution of autonomy and function to the group structure. The current overlap and duplication of the current range of administrations from command and centralised control to devolved care doesn't work, and it must be streamlined. 6, capacity within the community care system must be maximised to provide appropriate service in the community and to minimise the extent of acute and chronic care delivered in acute hospitals where appropriate. But it will not be able to deliver all of the care, and we must be able to provide capacity in the acute hospital system. Population trends, disease trends and outcome trends must be monitored continuously so that a robust manpower and service planning process exists so that we can identify service requirements. A uniform IT structure across all elements of the health service must be developed to avoid the present barrier to data collection and communication. And of course, we've got to address the rise in cost of medical negligence and ensure that whatever meager resources we have, they actually are delivered to patients. The remedy required is complex and it will require a long-term perspective, I think a generation. But the priorities must include the provision of adequate service capacity through appropriate staffing and capital development. The efficient delivery of services requires corporate organisational reform, and we must understand our clinical outcomes if we are to plan strategically, and we must. This cannot be achieved without adequate financial investment, but given the long-term horizon, the cost of reform, I would argue, is difficult, if not impossible, to accurately estimate. And there's no point in throwing figures around the place. But the point is, we cannot afford not to reform our current health system if good health is a national priority. To carry on as we are is simply unsustainable. Thank you.